Hey everyone, my name is Dr. DeVee, and I'm the PGY2 internal medicine resident here at Gatton. And today we're going to be talking kind of some pre-class content on the inpatient assessment lab. And so this vodcast is meant to be watched before the first lab. And so on the first day of class, we're going to have an in-class quiz over the content of this vodcast. So if you pay good attention, my goal is that you should be well prepared for that. The objectives of this lab are that I hope by the end of this you'll be able to identify pertinent medical information within a patient medical record. And this can be really tricky. There is a ton of information available to you in the inpatient setting. And so really learning how to best collect that information becomes really important in taking care of patients. So we're going to practice that on the first day of lab. We're going to collect some data, some patient data with patient monitoring forms. And so many of you probably haven't used these before, but really what they do is help you collect and organize that data. So that will meet that first objective there and the second objective as well. Also, by the end, I hope you're able to assess an inpatient's medication regimen, which is what pharmacists do best, right? And so by the end of this presentation, I'm going to give you some tips on things to focus and think about when you really have all these different data points about patients. It can be hard to kind of put things together, but if you have some key things and parameters to kind of focus your attention on, especially the things that pharmacists should focus on, I think that will help you. And then finally, by the end, you'll be able to design a plan with pertinent monitoring parameters for these patients. And so the second day of lab, we're going to be doing a care plan for these patients. So your first day is really collecting that information, and then the second day you're going to be working in teams to make a plan for this patient based on the data that you collected. Why is this important? As I kind of said before, there is a ton of information available to you in the hospital that maybe you're not used to seeing in the community. You don't always have the labs, the EKGs, the imaging, all these pieces of information that can really be key in treating patients. With that also comes a lot of error, and really if we can focus our efforts on managing this information, hopefully we can minimize some of these errors, which a lot of them tend to be medication errors as well. Prioritizing this is also key. So you need to learn when you should bring up the things that you find and what things are really important in the acute setting versus maybe something that could be followed up outpatient. And that can be tricky even in talking to providers and deciding what really needs to be addressed now in the acute setting and what can be maybe pushed later. Also, really practicing how to work up a patient and creating a care plan for this patient increases your job efficiency and accuracy. So this is going to take you all a good bit of time, as it should for your first time, but by the end, hopefully you'll feel a little bit more comfortable, and going into your fourth year rotations, you'll be able to work up these patients a lot better and a lot more efficiently, because you'll have a lot more of these patients that you'll need to be working up versus just one as well. So this is a really good practice for your fourth year. So where do you start? And just as this cartoon here shows, there are tons of ways to skin a cat, which basically means there's a ton of ways that you can look up patient information and organize your assessment and plan of the patient. And there's really no best way to do it, although I do have some recommendations for you. So first, to start at the beginning, there's two different types of charts. The one on the left here is the traditional chart, the paper chart. You'll hear it called sometimes. And then on the right here, we have more of the electronic chart. And honestly, most hospitals will have this electronic chart, but a good amount still have a mix of both electronic and hard charts. And honestly, there can be different things that are found in the paper chart as well. Like a lot of hospitals, there will still be EKGs and other discharge medications that this patient was on from maybe a nursing home that got transferred there. And so really, if you're missing something in the electronic chart, it can be a good idea sometimes to go pull the paper chart. Another important thing to talk about here is how to identify a patient. And this is important when you're talking about patients maybe on the phone to another provider, to your preceptor, to another another team member of the healthcare team, a nurse, something like that, you should always have two patient identifiers, such as the name, date of birth, and MRN, which is the patient's medical record number. And it's important to remember that room number is not sufficient. So you can't just call the floor and say, hey, bed 12, we need to add vanc. I will say that happens a lot more often than should. But really, if you think about it, patients are moving around all the time, and that's a good way to get yourself in trouble as far as errors go. Also, be careful of similar names or names that look or sound alike. So there could be two Miss Joneses, two Mr. Smiths. That's actually a lot more common than you would think. Or spouses sometimes end up in the hospital at the same time. So it's just really something to keep in mind. Also, this is a really big point, is that all papers with pertinent patient information need to be thrown away in the proper place. So, aka the HIPAA trash. You'll get a lot of this on your fourth year rotations. You'll have patient lists, and it's really important to remember that this is not something you can just throw away in the regular trash, and if you forget it and take it home on accident, you really need to bring it back to the college and have it properly disposed of. Now we're moving into the types of notes. So these are what is known as SOAP notes, and this is a type of note that you can be written, and it's basically just a acronym for what the parts of the note contain. So S means subjective, and these are things that are reported by the patient, things that you honestly really can't prove. So maybe they're saying, oftentimes they'll say I was, had a fever at home, and well, did you measure that? No, I just felt like my head was kind of hot. Or they were short of breath, or their heart rate felt like it was racing. So certain things that maybe you can't really measure or prove specifically. Objective information, however, is measurable data that we know. So maybe, Granny came in and said she was febrile all night last night. Well, today in the ED, her temperature was 98.6, and she's, that's our objective data. That was a normal lab that we found. So that's what you really need to think about is objective data. Labs, vitals, measurable things. A is your assessment. So honestly, this is where the physicians really come in with their differential diagnosis. So maybe if Granny has this fever, could this be a pneumonia? Could this be a UTI? What things could this be? And here it's kind of the summary of the problems that could be going on. The P is for plan, and this is what we're going to do about those things that could be going on. So if maybe it's a fever because of a pneumonia or a UTI, our plan would be we need to get a urinalysis, we need to get blood cultures, we need to get sputum cultures, we need to start antibiotics. Those are action items that we need to do to treat this patient's assessment, the problems that are in the assessment. Other types of notes we can have are, the first one's the most common. You'll hear it called the H&P. That's a very common abbreviation you'll probably want to know. And this is the initial note that's written upon admission of the patient. It's important to note that admission does not mean appearing in the ED. So this is actually if a patient is admitted to the floor, an H&P will be written. And this contains, you can kind of think of it as all the background information of the patient. So physicians really do a lot of data collecting for this first note. And I frequently pull this note if I want to go back and look at some past medical history or just things that were happening to this patient kind of at baseline before they came into the hospital. Progress notes are exactly that, the patient's progress from the original H&P note. So you'll have an H&P note, which is you can kind of think as your first note, and then the progress notes, which are kind of the updates that are written daily from the physicians. You can also have what's called consult notes, and these are if a specialist is consulted. So back to Granny, let's say, we're not sure if she has that pneumonia or a UTI. Well, maybe we want to consult infectious disease to help us out. And so they would have their own separate note on top of our history and physical we would write, kind of with their summary of what they think is going on. And you can trend those notes as well. Also in the chart, you may see surgical or procedural reports, and then a discharge summary. The discharge summary is where also a lot of pharmacists should pay attention to because those are the things that the patients are going to be going home with. And the plan upon discharge can be really important for medication reconciliation, and so we can play a big role there as well. And so the H&P, back to the H&P, the original note that I told you will be written, a lot of times these will be organized very commonly in a very organized manner, just like you see here. And there can be a lot of abbreviations here, and so I thought it would be important if I just kind of explain those to you. So chief complaint is often abbreviated CC, and this is exactly what the patient came in complaining of. Oftentimes you'll see physicians put quotation marks around what's said from the patient, such as, Granny came in and reported shortness of breath when she was walking around outside, but she was fine laying down, something like that. That would be their chief complaint. History of present illness is sort of the story leading up to their admission. So Granny was feeling short of breath when she was walking around outside, but not laying down. She was feeling this way for about 5 days. Her daughter came to visit with a virus, otherwise no other sick contacts. She presents to the ED today. Something like that. Something that tells a story about what made the patient end up here. Past medical history is that you should put a big star next to this because this is where I really pay a lot of attention. These are all the patient's medical problems that you need to think about. So maybe Granny has a history of COPD. She has a history of diabetes. She has a history of end-stage renal disease. And you need to keep a note of those and track of those because you need to make sure that their medications that they're on make sense with her problem list. So if Granny's has COPD, I need to make sure she's on the appropriate inhalers, both at home and when she's here. And those need to be fixed while she's in the hospital. Social history are honestly things like smoking, alcohol use, illicit drug use, things like that. Surgical history is just what you would think. Any surgeries that the patient may have had will be listed there. The labs honestly will be important to trend every day, and that should be something that you look at every day no matter what. Physical exam and review of systems is really where the physician comes in and does their examination of the patient and writes any comments there. Home medications is a big part that we need to look at, and as I said before, that should really match up with your past medical history. Allergies are also something that's important to pay attention to, and honestly, a big part of where we can make a difference is making sure that the qualification of those allergies is listed in a medical record. So if Granny has a penicillin allergy, but we're not sure what happened to her when she had it, that would be an important question for me to ask her during rounds because, it's likely that she's going to get a beta-lactam. So really reconciling that can help your team out a lot. Also, it's important to note that things will be left out of this H&P, and you may need to be a detective. So if I find Granny's on a random medication that I can't explain, that's a good place to start digging through the chart and trying to find, well, why does she have this medication? Is there something that happened in her history that maybe I can't find but did happen, or was this an error and it needs to be fixed? The next section is the labs. So this is part of the H&P still, and I think this is important to talk about as well because I don't know that we get this really anywhere else. But the difference between the different types of labs you can have here is the basic metabolic panel, or the BMP, which has the labs here, and these are called fishbone labs. But these are the basic metabolic panel just has your basic electrolytes. And this is very common that you'll see maybe some notes that list the electrolytes like this. So that would be a good thing for you to maybe commit to memory, is that the order of these fishbone labs. Complete metabolic panel is the same as the basic. However, it has your liver function tests and some additional electrolytes added as well. As I said before, paying attention to the labs is really important and something you should do every day. But as pharmacists, it's especially important that we know the creatinine clearance every day, because as we know in the hospital setting, patients' clearances can change very quickly, and adjusting medications becomes really important. A complete blood cell count, or a CBC, contains things like your white blood cell count, your hemoglobin, your hematocrit, and your platelets. There can be a whole bunch of different labs that you might see. Some of them are panels, like lipid panels, liver panels, or pharmacokinetic parameters, looking at different levels like troughs and peaks and randoms. You can have, A1Cs, BNPs, CPKs, all these different labs. And it's important to know that if you just don't know what something is, just look it up. Because even still, there's a bunch of tests that physicians will run sometimes that I don't know what they are either. But if you look it up, it will begin to make sense, and you can kind of put the pieces together. Vital signs, make sure you watch the units for height and weight. I know when I was staffing last year, we had a nurse that would notoriously mix up kilograms and pounds. And when you're dosing things like vancomycin, that can be a really big deal. So if you see a patient, that their weight is entered maybe as 130 pounds, and you think to yourself, well, that would be a really easy thing, 130 kilos. You think to yourself, well, that might be a really easy thing for a nurse to just type in wrong, because that's 286 pounds. So just keeping that in mind, I would always kind of call and say, did you really mean 130 kilos? Does that person really look like they're about 280, 300 pounds? And that's a very easy thing to check on. Blood pressure, heart rate are obviously vital signs that we need to monitor. Ins and outs. This is something that honestly I wish we had more data to track, but unless your patient is in the ICU, the outs really are not measured that well. If you have that data, however, that can be very, very helpful in assessing your patient's clearance. Another thing to kind of keep in mind is the oxygen saturation. So how much oxygen your patients are requiring. Are they on room air? Are they on a ventilator? Are they on BiPAP? Are they on CPAP? So just things to keep in mind. Microbiology is another important part of the chart. It's important to keep accounted for the date that these were collected, the site they were collected. So was it a blood culture? Was it a sputum culture? Was it a urine culture? Those are important things to remember and note. Also important to look at, when were the antibiotics given? Were they before or after the cultures were drawn? You'd be surprised how many times those get messed up. Also, it's important to track the results of your cultures. So if it just is reported as gram-positive cocci, you really need to trend that and make sure that you follow that. Could it be MRSA or is it MSSA? You need to continuously look at that each day and see if those result. And once they do, you need to look at the susceptibilities, the different MICs, and then from there, you need to make an interpretation on that. Is this a staph epi and a contaminant and something that you should just recommend not to treat? Or is it something like we found here, Enterobacter in the respiratory culture, that we probably should treat? And looking at this, what do we need to treat with? And for how long? The next part is probably something that all of us are a little bit more uncomfortable with, and this is the imaging and diagnostics. So certain things you can have here are EKGs, so looking at the electrical activity of the heart, CT scans and MRIs, ultrasounds looking at the echo or the heart function. You can have renal ultrasounds. There are a ton of other images that can be done, and honestly, most of it will not make a ton of sense to you. But there are important things that we can get from those, and I'll show you kind of here. So from this, when I'm looking at this EKG, I'm not going to totally pay attention to all of what's going on with the squiggly lines, but I can see here, look, they have sinus tachycardia with a first degree AV block, so their heart rate's fast and they've got a block. Also, I'm going to look at their QTC and see if any drugs need to be changed based on that. So not every image you need to, feel like you're making a ton of medical diagnoses on, but you can get data from these. Another one here is, I don't really know what I'm looking at here. Maybe there's something down here, but if I can look at the interpretation of this by the radiologist, I can see here, look, okay, this is mild CHF with a pleural effusion, pericardial effusion with pulmonary hypertension. So that can tell me a lot about whether this patient needs antibiotics. Do they see an infiltrate where it could be pneumonia? Honestly, I don't really look at the images. I look at the impression and what the radiologist says. Here's where your money comes in. For any medication, you need to at least know the brand and generic, the dosing range. So what's acceptable? What needs to be dose adjusted based on renal function or hepatic function? The indications for that drug. So why is this patient on warfarin? Are they on it for AFib? Are they on it because they had a DVT? Well, how long ago was that DVT? Do they still need to be on it? So these are questions that you should ask yourself every time you see a medication list. You also need to know the mechanism or of action, common and most likely serious adverse effects. So a lot of times you can kind of make some interventions here too. If we start a new medication and a patient complains of something a few days later, you can say, hey, maybe that was the X drug that we started a few days ago, because I guarantee you your physician colleagues are not going to be thinking of that. It's also important to know any contraindications and monitoring parameters for the drug. For the home medications, the first question I kind of ask myself is, can I trust this list? And honestly, that kind of comes down to who did it a lot of times. If a nurse did it, I automatically just go ahead and do it again. But if a pharmacist or a pharmacy tech did it, I tend to put a lot more stock and trust in that. But if you have missing drug or dose, frequency, or route, you can pretty much guarantee you need to do that again, because those are basic parameters that you should have on every home medication. You should verify the list with the patient or caregiver if possible, which is the optimal thing to do, but can be very hard when patients come in and they're so sick in the hospital. Maybe they have some altered mental status. They really just can't talk about things like that. If you can't, then it's best to call the patient's pharmacy or maybe track down some insurance data to find out their best list. And the next question I ask myself is, does the regimen make sense? And that, honestly, a lot of what I do compares with the past medical history. So if I see granny's on warfarin and I can't see a history of AFib or VTE, that's going to send a big red flag to me. Why is she on this? And if you can't find a reason, then that's a red flag. Are there medications missing? So the opposite could be true. I could read Granny's past medical history and see, well, she has AFib and her CHADS-2 score looks like it's about 4. Why isn't she anticoagulated? And sometimes there's a good answer to that, but asking that question is still important. And sometimes the medical history just can be missing, so they forgot to write it in their note. But they can look back at some of their records and see, oh yeah, she did have, a PE in, last year. And so that warfarin for her is appropriate. So really, when you look at the regimen to see if it makes sense, oftentimes you'll come up with these questions, and it's just important to get more information. And that comes back to being a good detective. On home medications, the third thing you should really trend is any changes that are made to the home medications. So every day, compare the inpatient meds to the home meds. What's changed? Have we not restarted Mr. Jones's Lasix, and maybe he's starting to get a little fluid overloaded, and it's time to restart that now? What are we holding and why? And continuously, try and ask yourself, is this the right time to start this back? Also, it's important to know the plan for home meds that have been changed. So are we just not going to send Mr. Jones back with this Lasix? Do we not think he needs it anymore? So the bottom line is just to keep track of those changes to the home meds and really own those. Inpatient medications, there's 2 different types: scheduled meds and PRN or as needed meds. For the scheduled meds, again, we talked about reconciling the outpatient and inpatient meds kind of noticing the differences there. Again, you'll see the drug dose frequency route, and then part of your job will be screening for drug interactions, drug appropriateness, and any dose adjustments that are needed. For the PRN meds, you may see something that's called comfort or standing orders, and these are just orders that a doctor may put on the patient's chart should they need them. So a lot of patients will have things like insulin on there, where maybe they don't take insulin at home, but it's on there should their blood glucose elevate to a certain level. Or maybe a patient will have PRN inhalers that maybe they don't use at home, but they're a little bit short of breath right now, and so in the future, should they get that way, then they have it. Another really important tip here that I can give you is sometimes we kind of don't pay attention to these PRN meds because they're not used every day, but some of it is important to trend. And two good examples I can think of are pain meds and insulin. So for pain meds, if you can see, Mr. Jones is needing his Lortab, that's Q6, he's getting it Q6 on the clock, you can set your watch to it. Then maybe it's time to start thinking about if he needs a long-acting scheduled pain med and then something for breakthrough pain. So things like that, kind of staying ahead of the game. Another big one is insulin. So if you can see Mr. Jones is requiring a ton of sliding scale insulin, just PRN, maybe it's time that we go ahead and schedule like a long-acting Levemir. Don't forget fluids are medications. So that can be something that's really hard to monitor as a patient's fluid status, but you can do a lot of harm if you don't assess the appropriateness of fluids. And don't forget to pay attention to the rate that they're running at. If a drug requires pharmacokinetic monitoring, make sure you're doing it if it's appropriate. So is it time that the patient gets a vancomycin trough level? Does a patient come in with altered mental status and look, they're on digoxin at home? Maybe it's a good idea that we go ahead and check a level. If a drug can have any type of monitoring, you need to assess whether or not you should do that. Another good tip is to pay attention to anti-infectives, whether they're appropriate, and then keeping track of the day of therapy that these patients are on. Another good tip here is the anticoagulants. You want to keep a good eye on whether or not they have the appropriate indication and dose. It's also important to note that any new medications that are started in the hospital are an education opportunity for you, for the patient really, and for you. But what can be done is some discharge education for the patient, just on what medication started, if it's maybe a short-term thing, kind of some counseling about how long they should expect, and then just your typical pharmacist, the dose, duration, and common side effects to expect as well. Other considerations, just remember to not just treat the number, but to treat the patient. So a good example of this would just be, certain labs, maybe their clearance is 31. Maybe it's a good idea that we err on the side of keeping more drug for the patient, even though that number doesn't read exactly 30, but keeping to dose adjust a drug, remembering that the patient maybe needs to have more of this antibiotic, and that would be more beneficial for this patient rather than treating just the number, because as pharmacists we realize that creatinine clearance is just an estimation anyway. So just kind of keep that in mind. Also important to track the trends. So if you can kind of notice that a patient's blood glucose is trending higher and higher each day, well, maybe it's important that you decide what type of insulin should be started for this patient. So it's important to notice the trends that are happening so that you can come up with your assessment and plan. Don't forget any social history that may affect your assessment and plan. So we can come up with the best assessment and plan for this patient, but if they can't afford a medication and can't get it outpatient, then that really is not going to do anybody any good. Bottom line too is if you don't know what something is, just look it up. That's honestly, a lot of preceptors' big pet peeve is if you don't know what something is, just presenting them with a problem that you don't know what it is. Really take ownership of this and look things up when you don't know what it is. As I said before, you're really the detective when you're in the hospital. So if you can identify any issues and anticipate the needs of your team and patient, you will really make great strides with your team and take the best care of patients. Also important to really think about when the best time to ask these questions or to come up with to give your recommendations to your team. So maybe you notice that this patient is on Pepcid and their clearance has really dropped and it needs to be dose adjusted to just daily. Is that something you really want to page the doctor about at 2 o'clock in the morning when you happen to find this? Probably not, right? That's not going to do a lot of harm. So waiting until you pass this doctor in the hallway at 9 a.m. when you know he's going to be walking through on his rounds and just asking him then, that can really give you a lot of rapport with your team and also just take better care of the patients and not annoying your team. Also being a problem solver. As I said before, if you go to a physician with a problem, make sure you have in your back pocket a solution that's ready. So if you see, a patient's culture and you notice that they're maybe just on penicillin, but they have MRSA, well, if you just come to a physician and tell them that you notice that problem, that doesn't really help anybody. But if you say, hey doc, look, Miss Jones in bed 25 has MRSA now in the sputum. We can't use daptomycin, but we can use vancomycin. Do you want me to go ahead and dose that for you? That really will give you a lot of rapport with your team, and as I said before, that is the best care for the patient. Okay, now we're going to go over the monitoring forms that you'll be using in the first day of lab. And these are important for collecting information, keeping that information organized, and ultimately help you in synthesizing an assessment and plan, as well as tracking any follow-up items or progress notes that need to be done for the patient. So when you're on your fourth year rotations, a lot of times preceptors will require that you use these forms because they give you a nice organized way to kind of collect your thoughts. So I'll show you the one that you'll be using in lab. And I've just kind of broken it down here. You can see the patient's name, the room number, the admit date, any allergies. As I said before, it's important to qualify those allergies, whether it's a true type 1 anaphylaxis reaction or maybe just an intolerance. The patient's age, the patient's sex, the height. Again, pay attention to units here, inches or centimeters, sometimes it's reported as. The weight, and then every day you should be calculating the creatinine clearance. Here we have the chief complaint. So again, the number one thing that's bringing them in, their story behind it or the history of present illness, the past medical history or the problems, the medical history problems of the patient, past social history, family history, that's surgical history, family history, and social history. The home medications, you have here the medication type, the dose, the frequency, and then the indication. Here you can track any vitals that the patient has, and as well as the date. Here's where you can keep track of the diagnoses that you're working with, and these are, again, the current diagnoses, so sometimes these are differential. So HCAP versus COPD exacerbation. Here is the inpatient medication list. So you have the medication, the dose schedule, any monitoring or comments, when it started, when it's scheduled to stop, and the indication. Here you have the cultures, the date that it was cultured, the specimen, the organism. And this plus or minus just means whether it was a positive culture or not. So maybe you drew a blood culture and it never grew anything, so you could put a negative there. Any diagnostic procedures that you think are beneficial to note in their results. And then their labs. So I told you here the fishbone or skeleton labs, as well as a more thorough list of it on the next page about the other miscellaneous labs. So you'll have this form available to you on your first day of lab. So there will be a pre-lab quiz, which will be in class, which is about 5 questions over this Vodcast content. In lab, the first day, you're going to work individually to complete the monitoring form. So you'll be given a case, and really you're just going to be reading through that case and collecting data and filling out that monitoring form I just showed you. Make sure you only write on those patient monitoring forms and not on the patient charts themselves. Thank you guys, and I look forward to seeing you this week in lab.